right. Welcome back to the Progressive Rehab and Strength Podcast. I'm your host, Dr. Rori Alter, head clinical coach here at Progressive Rehab and Strength, with another lovely clinical coach here at Progressive Rehab and Strength. Many of you who have been listening to the podcast are very familiar with Alyssa and John, both doctors of physical therapy and clinical coaches here at Progressive Rehab and Strength. But we are joined here today and for the next couple of episodes with Dr. Breanne Maruca, a clinical coach here at Progressive Rehab and Strength and physical therapist who specializes in pelvic health. So what we're going to be doing this month is we are going to be talking about all things related to the core, the inner core, the pelvic floor, and types of dysfunction that people experience outside of training and inside of training, but those things outside of training certainly relate to inside training. So without further ado, Bree, can you just give us a short introduction as to who you are, what your certifications and background are, and then we'll dive into the functional anatomy of the inner core and the pelvic floor.
Yeah. So, Rory, thanks for, of course, having me. I mean, I obviously being a part of your team, but especially on the podcast that we get to let people know and discuss these important topics because, gosh, just because something is normal, and you will hear this throughout all the
I'll always
episodes.
say this a million times.
Yep. Just because something is normal, or sorry, just because something is common does not mean it's normal. So, this is where, I really feel like the inner core, pelvic floor, and all things kind of surrounding it. There's a lot of things that we might not fully understand, or there's a lot of misunderstanding about it, or buzzwords and things that people just like hop on the bandwagon and say, this is what everyone should do, or this is how you should do it. And it's like, just depends. So anyway, thank you, for having me here. But first off, as Rory said, I am a doctor of physical therapy. I continued on with my education and did a residency program through the University of Pittsburgh Medical Center. It was about 2 years long-ish, and that was to become a board certified pelvic health physical therapist. So not only in this residency did I work with a lot of pelvic related conditions and different populations. So I worked with men, women, children, of all different ages, of all different backgrounds, with all different diagnoses and surgeries. And it was amazing. Honestly, like the best experience ever. And I learned so much, especially from all of my mentors. But after completing the residency then, and actually while I was in my residency, that's how Rory and I met. We were at a conference, both presenting regarding special cases related to pelvic floor, pelvic health. So we met, and since then I've been working with men, women, children back in my hometown in the clinic, as well as with Rory through PRS, doing virtual pelvic rehab coaching and barbell coaching and barbell training. So kind of getting a little mix of everything. And yeah, so that, I guess, I don't know if there's more, more about me.
Why don't you tell us just a little bit about your background in strength and conditioning and exercise, your athletic background, basically, and how we really came to connect on barbell training.
Yeah. So, I mean, I guess going way back, I've been involved in sports and being active and outdoors and all of that since I was really little. I danced, I think, starting at 3 years old, and then got into softball, basketball, volleyball. I don't know, you kind of name it. I either tried it or really loved it. So, and continued with it. So all throughout high school, I, continued those sports, and then getting into college, I still kick myself in the butt. I wish I would have played college softball, but that's whatever. It's let bygones be bygones, I guess. But yeah, I focused on my studies. I was definitely a person who needed to study a lot. So I focused on my studies.
I can attest to that.
Yes. Yeah, it was just like, okay, softball or, a career. And that's kind of where the route I went. But but I stayed involved in intramural sports and summer sports and things like, summer leagues and things. But overall, I got into barbell training, specifically a little bit more related to like Olympic lifts with CrossFit. And I'm now a level one CrossFit certified CrossFit coach. Um, but that's kind of where we got into where I was starting to get into more into barbell training. And when Rori and I met, it was just like, oh, there's so much more to this than
Mhm.
first off, than you're ever taught in general playing sports and growing up in
Mhm.
the athletic realm. But then, especially in PT school, I'm like, okay, well, did we ever really learn how to squat optimally? Did we ever really learn how to like hip hinge and deadlift and,
Mhm.
what all of this means related to not only people barbell training, but um, any population, how we can tie this all into function
Mhm.
inside and out of the gym and symptoms inside and out of the gym. And we just dive deeper and deeper and go down all these good rabbit holes, not in a bad way, but
No, I know it's
um
so much. It's fun. You and I, honestly, like this month of podcasts might be really long episodes, guys.
it's good.
Apologize in
Yeah.
advance.
Not only do we just like are we super passionate about this, but it is kind of interesting even when like as we start getting into these conversations that we start to like our brains start to turn and we're like,
Yeah.
ooh, yeah, like great point. And like it just ties things together more and more. And I think that's why I love like specializing in this area of PT so much because it's kind of the central missing link of like a
Mhm.
lot of things and it just pulls pieces together. So, yes, I specialize in like the pelvic area, abdominal area, but it's almost like well you need that at least in my like my thought process is like you almost need that piece to connect hip problems and then shoulder like there's all
Mhm.
these,
Mhm.
it kind of starts at the core and we'll
Mhm.
get into that more but yeah.
Yeah, so just to touch on the how you and I like actually met and what we're talking about when we say like we can just talk for hours.
Yeah.
So we were at the American Physical Therapy Association's Combined Sections meeting, which is an annual conference that they have where all the different sections of physical therapy, so pediatrics, sports, neuro, oncology, like everything,
Ortho, Jerry,
everything, pelvic health, geriatrics, like there's so many more that like I don't even know about, but they all come together and there's large presentations and short presentations, research being presented, round tables and case studies. And so in 2019, you and I presented in the complex cases for pelvic health. And I brought a case that I had been working on about urinary incontinence and powerlifting, and presented. It was like a 20-minute case study presentation. And then Bree presented on one of her clients as well. And we just really connected after that. And the panel was very interested in learning more about powerlifting urinary incontinence and how I, as a physical therapist who does not have an educational background in pelvic health, like I didn't do the residency, I'm not a board certified pelvic health specialist, I'm an ortho sports PT. How did I treat this person? And they wanted me to go like deeper into that and present a 2-hour presentation. And I was like, oh dear gosh, I can't do this
yeah.
without Bree. And Bree had come up to me after that presentation. We really just connected
This
because
is
of
awesome.
your background in CrossFit, and you were just like, I want to know more about this.
Yeah,
And
like this is
so
awesome.
yeah, so then we just became friends from that,
Mhm.
and I said, Bree, they want me to present on this. Would you be my co-presenter? So we spent the entire next year.
Literally.
It was a full year of gathering research. I had already done this research because we have, with my husband, John, at Adelphi University, we had already done a study, collected data for a study on powerlifting urinary incontinence, which maybe one day we'll actually write up the paper and submit it. And we really should because there's been so many more. We did that in 2017, and there's just been so much research that has come out since then on the topic of pelvic health issues in resistance training and barbell training. Um, But anyway, you and I spent the next year really diving into that research even further, putting together a presentation and really defining what powerlifting urinary incontinence was, or is.
Mhm.
And then we presented together, and then COVID happened.
Then
right
and the
away, like
world changed.
COVID happened. I got
Literally
pregnant.
that
That
week
was that
after,
week
like
we
it
got
was,
home.
yeah.
Yep. That week we got home, I found out I was pregnant.
Yeah.
Intentionally pregnant, like it wasn't a mistake. JD is the love of our lives over
Mhm.
here. And the world shut down. So, but you and I have been working together. You've been here at PRS since 2019.
Mhm.
I've been referring all of our pelvic health cases, our abdominal issues, to you since 2019 directly through PRS. So it's not like you work independent. I mean, you work independently in the clinic, but you're like
We're
related.
located in different like
Yeah.
Rory's in New York, I'm in Pennsylvania. So
Right, but
people weren't traveling from New York to come see me like in
right.
person, but
But, you know, any clients that we get that are directly related to pregnancy, postpartum, um pelvic health issues, abdominal surgery, like whatever,
yes.
hernias, all those things, they go through Bree first, before they go to any other coach. So, with that said, I
Yes.
told you these are gonna be long episodes. um, so what we're gonna do in this episode, this is our functional anatomy of the core and pelvic floor region. But the core musculature and the way that the core functions, and the pelvic floor musculature and the way that the pelvic floor functions, all tie into the bones and and the anatomical structures, the ligaments, and the hip muscles and the back muscles that we've already talked about in our functional anatomy episodes of the hip and the back. So we're not going to dive into the structure of the spine and the hips. We're not going to dive into the ligaments and muscles in the hips and the spine, because you can go back and listen to those episodes, which hopefully you already have. But if you're new here, go back and listen. So Bree, let's talk about the, like you said, the core is the foundation for our body to function on, right? So we have our
I,
brain that kind of tells our body what to do, but then we have our core, which our limbs, our appendages are attached to. And without our core functioning properly, um, the everything else probably doesn't function optimally. So,
yes. Well, and I always use this example. I always say, like, think of it like the foundation of your house. When you build a house, like every layer, or I don't say layer, but every floor that you build on
right.
top of that
Mm-hmm.
foundation, it's dependent on a solid foundation. So
Mm-hmm.
if you build a 2-story home and the foundation is wonky or just not as sturdy or doing what it's meant to do the optimal way it should be,
Or there's a
you're going, yeah,
leak, or
yeah,
like
a creaky
you'll get
door, you're,
mold.
yeah, like it's just,
Homeowners over here, we
yeah.
don't. Let's just rent for the rest of your life, guys. You
Yeah,
don't have to
knock
deal with
on
those
wood. Let's just like not speak any of these bad things into existence for our homes. But yeah, so you want to think of your core, and we'll dive into what exactly we mean by the core, inner core or foundational core. Um, we want that to be the most solid foundation that we can build off of. And again, you may have heard Rory or any of the other coaches maybe mention this, but you're only as strong as your weakest link. And usually that involves our stabilizers. So when we're looking at the foundation of our house, if yes, we could have these great structures and everything built off of it and all this fancy, good bricks and da 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 da, all these other things. But if that foundation is not solid, something's going to give somewhere, and eventually or quickly, it just depends on what, um, something will give, and that increases your risk of injury. And doesn't, again, we look at all the goals of the PRS goals that we go by here, with maximizing your strength development, the most moving in the most effective range of motion,
mm-hmm.
longevity, et cetera,
Mm-hmm.
et cetera.
Mm-hmm.
So yeah.
Yeah, and so I just want to point, like, tie in right here. Ultimately, our bodies are designed to work properly.
Yes.
So, the body that you're given, in the absence of a dysfunction, in the absence of a trauma or an injury, or um, some type of extra stress to your body, disease, illness, physical or mental,
Stress
emotional
doesn't
stress,
matter.
whatever, fatigue, your body should be working properly. So that foundation, when we, come out of the womb and start growing, that foundation should be solid. It should work properly. Our bodies are designed neuromuscularly to work. There's a lot of automatic functions in our body. So we don't want you to just kind of default to the, oh gosh, if I don't address my inner core, I'm going to have a problem. Because
Yes.
your inner core should work and fire, I'm going to put that in quotes, appropriately, because it's designed to do that. But when we have some type of external stress or trauma, or even internal stress or trauma, disease, illness, whatever, that starts to affect us, then the inner core possibly could be affected, right?
Yes.
So, yeah, what were you going to say?
And I was going to say, and then possibly, again, just because your inner core might not be working as optimally as it could, that doesn't mean that you automatically are going to have urinary incontinence. That doesn't automatically mean you're
Right,
going to have back pain or prolapse
right.
or a hernia or et cetera. It's there. There's a lot of pieces to the puzzle, and everyone's
Uh-huh.
pieces are different.
Right.
And when we finally get to that point of our body showing symptoms
Mm-hmm.
or, presenting in those ways, that's when we need to like go back and say, okay, let's problem solve this and let's figure out where the root of your problem might
Right.
be. And is the core a piece of that? Is that a piece of
Exactly.
it?
Exactly. So let's look at the core from the outside in. So, yeah.
Yeah.
So let's just describe like the muscles, the fascia, and all the things. Because I think a lot of people think of their core as like their abs, but what does ab mean?
Yes. So, yes, we refer to our core, our abs, as like a general group of the muscles that we typically see if we have our shirt lifted or we're in a bikini or, bathing suit or whatever. You can see some sort of muscle bulk or something when you move. You can see contraction of some muscle. Though that's what we're referring to as our abs. What's in the front of our belly, and what you see if you're looking in the mirror or looking at someone else. But yeah, we have actually 4 main abdominal muscles. And before we even get into those, when we look at muscles in general, we think of movers and stabilizers. We kind of break them up into these 2 more general groups throughout our whole body. So our movers are the muscles that create a large range of motion, are usually creating more power or just a lot of motion, a lot of power, a
Mm-hmm.
lot of movement. Our stabilizers are what's that foundation in a way, or things that are keeping things from not moving as much and keeping things stable. So when we start from the outside in, we look at our external obliques. Those muscles go from our ribs down, and they come from the outside in. So like if you're putting your hands in your pockets, that's your fingers are the direction of those fibers. So
Mm-hmm.
from the outside in, they go from your ribs down to into the linea alba, which is just a connective tissue that it's the line that goes completely down the middle of your belly. It's just a thick connective tissue. And what's super interesting actually about the linea alba, just as a side note, is it's a little bit based off of genetic, or not a little bit, a lot based off genetics and how thick and dense that tissue is.
Mm-hmm.
So there's some people you've probably heard of that, oh, I could never get a 6-pack no matter how hard I tried. Or there's someone that literally eats chips and cookies every day and they're like, look at my 6-pack, like it's great. Some people just have thicker, denser
Mm-hmm.
connective tissue
Mm-hmm.
that allows for that definition, and some people
Mm-hmm.
don't.
Mm-hmm.
But so that line down the middle that you usually see in between your 6-pack muscles, more specifically, that's that linea alba, that's that connective tissue. So the external oblique goes from the ribs into that middle line or that middle connective tissue. And it also attaches onto the pubic bone, pubic symphysis, and the iliac crest, which is just the top of the pelvic bowl, essentially. Then we have,
I'm going to interrupt. I'm
yeah,
curious about this genetic component of the connective tissue. I'm curious when it comes to hernias and DRs, diastasis recti, are people
yes,
more susceptible to hernias and DRs if they have a like less connective, the weaker of the spectrum of connective tissue? I'm curious.
yes. I
That
mean,
genetic component.
I was going to say, I don't know if I've read any research specifically on that, but I would imagine that, you know, and we'll get all into talking about this, whether it's today or another day, but, you know, most of those hernias and DR and all of that stuff, those types of symptoms and diagnoses that we could possibly get are because of a pressure moving into a path of least resistance. And yes, I would imagine that if your connective tissue is inherently less dense or
Mm-hmm.
inherently less thick, that path of least resistance could be that linea alba or
Mm-hmm.
that connective tissue, those connective tissue areas, or the
Yeah.
inguinal,
Mm-hmm.
umbilical,
Mm-hmm.
etc. So then when we get into the internal obliques and the rectus abdominis, again, these are both what we consider more mover muscles.
Mm-hmm.
The internal obliques are kind of going the opposite direction as the external obliques. And these internal obliques start from the back. We have a connective tissue in the back. It's called the thoracolumbar fascia. And that the internal obliques attach there and onto the back part of the iliac crest. So again, the back part of the pubic or the pelvic bowl, and they come up and in and attach up and into that abdominal connective tissue. We refer to it as like the rectus sheath. It's just another abdominal. There's so many layers of our abdominal connective
I'm
tissue,
just
but
going back to PT
yeah.
school. Like the external obliques are like your hands in your pockets, and the internal obliques are your thumbs, right?
Yes.
Yeah.
Yes. Yep. Exactly. Yeah. It's so funny. Yeah.
The
We go
funny
back
things
and
that
like,
you remember that you like use to remember things in PT school.
yes, but it's a good visual to kind of
Mm-hmm.
see how those would maybe work together or
Mm-hmm.
et cetera. So we have those internal obliques, and then we have our rectus abdominis muscles, which is probably one of our most, commonly thought of abdominal muscles
Mm-hmm.
because that's our six pack muscles. These muscles are like railroad tracks going from our ribs in the front of our body, the xiphoid process, which is just a little bone between the two, like coming off of your breastbone. And they go straight down into the pubic bone. So the pubic symphysis, the pubic crest. And these muscles, so they're going up and down like railroad tracks medially or on the inside of those group of muscles or those railroad tracks. It's connecting to that linea alba, again, that middle connective tissue. And then on the outside of those muscles or the railroad tracks, they're connecting to also connective tissue, the abdominal connective tissue sheaths. So, and they also connect then into the other kind of uh, ligaments and of the other abdominal muscles. So they all, when we start talking about the abdominals, and we love to say, oh, this muscle does this action, this muscle does this action, but they all really work together because they're all connected. So going then into the last and the deepest layer. So we just went from outside to inside of our body. If we have shirts on, your
Mm-hmm.
sweatshirt was your external obliques, your t-shirt is your internal obliques, etc. So deepest layer, we have our transverse abdominis. And this particular abdominal muscle is what we will be referring to and talking about a lot throughout these episodes because the transverse abdominis is our deepest abdominal layer, and its nickname is called our natural lifting belt. So the way that it's oriented, where it starts and ends, and the way that these muscles contract and work is why it gets its nickname, because it looks like a belt and it compresses and it just gives that function is wrapping around the belly like a belt. So this muscle, this group of, or this, the transverse abdominis muscle starts back in the back again from that thoracolumbar fascia, our cartilage, our ribs, and it wraps around again, just like a belt, coming into the, again, abdominal connective tissue, abdominal tendons, onto the iliac crest in the front. So again, front of the pubic bowl, and it just kind of fuses into the other fibers of these connective tissues. So
Mm-hmm.
as a group, specifically, yes, the rectus abdominis or your six pack muscles, when we think of movers, that muscle in particular is more involved with flexing or bending at
Mm-hmm.
the spine. And then of course the obliques are more involved with rotating of the spine. So Russian twist, that's a, common, or, just twisting,
Yep.
turning. And then again, the transverse abdominis more specifically is involved with compressing, stability, compacting. That's
Mm-hmm.
more of its function. But again, together, these muscles all work together, and tension is created when they're all working together to create stability.
Yeah. So, I talk about Doug, my client Doug, on this podcast a lot because he comes in
Mhm.
person twice a week and he is just all about learning. He listens to the podcast. He always has questions. I say this to Alyssa all the
You've
time.
asked me questions. Like I remember he's a familiar name because I remember
Yeah, yeah.
you've asked me a couple of things here and there.
He gets it. I always say that he gets his own private podcast in the garage because he's like always learning. His sessions take a little bit longer because we always have a little mini 10-minute tip episode in there.
Yeah. Aw.
I should record our
You should
sessions.
record it.
I know. But one of his questions was, how come we don't train abs? How come like you don't have me doing sit-ups or crunches or whatever? And I said, really, when in your life are you only like flexing your spine, and what and when in your life are you really doing like resisted trunk flexion
Yes.
as the prime action of what you're trying to achieve? So can you talk a little bit about why, like, how our body functions and why we don't in the absence of dysfunction, why we don't necessarily have to train trunk, like the abs,
Yes.
like
So
isolated abs?
yes, and there is a point, and when we get into more of the dysfunctional end of it, we'll
Right, right,
discuss
right.
why and when we actually do
Uh-huh.
train the core more. But in the absence of any dysfunction, um, we don't need to train the core because the core is always working. Again, it's our foundation of our house. It is the center of everything we're doing and the center of our movements and everything. So if we are if this core, and the core is meant to work, we talk about Valsalva being, necessary, automatic, safe, and adaptive.
Mhm.
It's really, that's the function of the core. It's the core is working automatically. It's adapting to what we're doing, increasing the contraction or decreasing, not contracting as much based on the demand we place on it. So if we are, if we are barbell training, or we are dumbbell training or kettlebell training or whatever training, and we're progressively resisting, and progressively training these muscles, that core should be also right with it, getting stronger, becoming training in a more dynamic way. Again, our core is very adaptable, and it
Mhm.
adapts to what we're doing. So in our brain, we have these motor patterns and motor, programs that, okay, say you have learned to do, like, again, going into a sports realm, say you've learned to do something, an upper body sport where you're primarily throwing or hitting or something with your arms, just because that core is so adaptable that if you've been training in that way of some upper body sport, you likely will be pretty good at a different upper body sport just because your body has been, has been trained to
Mhm.
work in a certain way. So I guess long way about that.
Yeah, no, I think you're on it, and I think that our body. I think one of his questions was like, I think this goes back to like movers and stabilizers, right?
Mhm.
So we do have, when we look at the core, the general function of our core musculature is to stabilize our body. So even though the rectus abdominis could be considered, and the transverse and external oblique, not the transverse, the external and internal obliques could be considered movers, they're actually, their prime function in life is to stabilize, right?
Yes.
So, and this goes down, we look at every single muscle, like there's not just one function for each muscle. Like our our quads will stabilize our knee, but they'll also move our knee.
Yes.
And so there's this spectrum of responsibility of the muscles, and even though we have our outer core as being more of the movers, the
Mhm.
whole function of the musculature of the spine or the core is to stabilize. So
Yes.
the like, I'm trying to think of like when you might do resisted trunk flexion, and we're trying to think like when you're getting off the floor with a load in your hands, like really we do trunk flexion when we're sitting up from something, or I'm trying to think like what other actions might be trunk flexion, like against gravity
Yeah, that
or
you're going,
resistant,
yes.
you
Mm,
know? There's not many, you know? So
mhm.
getting off the floor or bed with a baby in your arms or like a grocery bag or like a book, I don't, you know, so they're not major, like that's the action of trunk flexion. But then when you're thinking of something like pushing a door open, yes, that is, your trunk is concentric, like it's a concentric contraction of your trunk because it's, I'm sorry, isometric. I didn't mean to say concentric.
Yeah,
Your
or
trunk,
even eccentric too. Like it's almost like a dynamic
yeah,
stability as well. Like you can
yeah,
have that static stability where,
yeah,
okay, you're deadlifting or you're squatting a lot. Like we need that static stability
right,
of our, or we don't
right,
want any extra movement in our trunk area.
right,
But then when, how you said, when you need to stabilize but also move,
right.
it's almost like this dynamic
It works
stability.
more
Yeah.
eccentrically and
Yes.
isometrically than it
Mhm.
does concentrically
Yes.
throughout our function. And that's why we talk about functional anatomy.
Yes.
Your muscles can do actions, but how they actually function in daily
Yes.
life is different than what they actually do, if that makes sense, you know? Um, so in the absence of dysfunction, you don't need to be doing sit-ups. In the absence of aesthetics, you don't need to be doing sit-ups or oblique exercises or things like that. But so if you're squatting and deadlifting like you are, Doug, and anyone else who's concerned about it, you know, you're never going to be able to do an isolated sit-up with 200 pounds, but you can deadlift 200 pounds, you know? So your core and your core musculature are working harder when you're deadlifting 200 pounds than when you're doing a sit-up with a 10-pound dumbbell.
Yes. And also too, like, and I don't know if this is a conversation for this podcast, but when we think of fatigue and we talk about symptoms and
Mhm, mhm.
fatigue related symptoms, especially, um, think of when you do like a core workout or a core whatever accessory work, you get so fatigued in those muscles. But when you are squatting, deadlifting, like, yes, you get fatigued, but it's such a different fatigue.
Yeah, it's like a generalized, your whole body is fatigued, so your whole body's going to function fatigued, you know, versus,
Yes.
and also like think about how hard it is to function when you have like sore abs. Like it hurts to
Mhm.
cough, it hurts to reach
Stand
up.
up from a chair,
Yeah.
like, you're just like, you're laying in bed and you're just like, "Oh, I don't wanna move." Like,
Right, exactly. Like
honestly.
it actually like it can lead to dysfunctional movement the more sore you are. So I mean we don't have to but I yeah, this
Yeah.
would be a whole other podcast that we could talk about. So we've talked about the um so the function, just to sum up what the function of the anterior abdominal
I was
muscles
just
are.
gonna,
Yeah.
yeah,
So
that's great.
so we've talked about the posterior core muscles in the spine functional anatomy. So these are the anterior core muscles. And just kind of going back to that transverse abdominis being your natural weightlifting belt. So when we when we function throughout daily living and we lift things in training and moving and all this stuff, those core muscles are isometrically and eccentrically contracting to stabilize our spine, our torso, so that our arms, our legs, our head can function properly. Every movement that you do with an arm, with a leg, with a toe, with your eyes, causes a is associated with some type of contraction, low level or high level contraction of your of your core muscles. And I'm not just going to say abdominal muscles, I'm going to say core muscles because
Mm.
also your pelvic floor, right? And we'll talk about that and shortly. But the other thing is that when we are doing the Valsalva, just to kind of tie the anterior musculature into the Valsalva, you talked about the transverse abdominis being that natural weightlifting belt, but basically when these muscles contract, we take a big breath in and hold it, and these muscles contract down. We don't bear down, like that's a whole other conversation. Go back and listen to our Valsalva podcast. They're increasing intra abdominal pressure, which increases the stability of our spine. and increases the stiffness and rigidity in our torso to create a solid foundation, like we were talking about at the beginning of this episode, to then function with our by moving the barbell on a solid foundation. So if we're not stiff and rigid and solid in our foundation, which is our core, our torso, etc., then our movement isn't going to be as optimized, and we won't be as strong as possible when we're moving. So with that said, let's move on to the diaphragm.
Yes. So just to put this into perspective and what Rory just said, the core is not like the abdominals are not the only part of our core. And the posterior spinal muscles are not the only, these are not the only parts. The center of our body is not the only part of our foundation or
Are you going
foundational.
into, I think we should, are you going to talk about the cylinder?
Yes.
Okay,
yes.
good. I was like, we probably should have started with that.
No, we left like the teaser, right?
Yeah.
Like this is like diving in deeper now. So again, that's what we typically think of. And yes, those center muscles in the center of our trunk are super important for core stability, foundational stability. However, that's not all. We have, almost think of it like a can. That's a perfect example. Let's think of a can.
A soda can.
A soda can. Can has a top, the can has a center, and the can has a bottom.
Mm-hmm.
The center of our can are those transverse abdominis, internal oblique, external oblique, like all of those,
and the back muscles,
quadratus, lumborum, all of those, all of those muscles. That is the center of the can. Think just like you could visualize the center of our trunk. Above that, though, the top of the can is our diaphragm muscle, and this is usually referred to as like our breathing muscle. This muscle sits under our rib cage. It attaches to all of our ribs, but it almost is like an umbrella underneath the rib cage. And when this muscle contracts, it actually pulls down, like the direction of the contraction. So usually when we think of muscles contracting, we think pulling, like shortening, tightening, and it is shortening and tightening, but the way it's connected to the connective tissue it's connected to in the center actually causes like a pulling down effect. And so the diaphragm not only, of course, is what allows us to breathe and stay alive, but it also it's the ringleader of our inner core system and that foundational system. So this is where we get into breathing with Valsalva, et cetera, is the breath and the breath hold that sets, and what is happening at the diaphragm, that sets the stage for the rest of the inner core muscles. So all of those abdominal muscles or trunk muscles, and then as well as the pelvic floor, which is the bottom of the can. And we'll dive into that a little bit here, but in general, the pelvic floor muscles are the bottom of that can, and they play a big role at stability at the bottom, and then diaphragm plays a role at the stability at the top. A good way to visualize this, when all of these muscles contract together, which again, they are a group, a team, and they are the group of the inner core, foundational core. When they contract, I always say this, whether you are somewhere where there's snow or you're at a warm place where there's sand, either or, think of it either as a snowball or if you're packing sand to make a sandcastle. When all of these muscles contract and contract the way they're meant to, you are making like the best snowball to like throw as far as you can and hit someone really hard.
Yeah.
Or like, the sandcastle that's going to withstand all the water in the ocean and the waves. It's compacting. It's creating this, again, when Rory just said, like visualizing stability and rigidity, that is when all of these muscles contract together appropriately in the way they're meant to, it's creating that compacting motion and that stability.
Mm-hmm. So on inhalation, the diaphragm descends.
Yes.
And on exhalation, the diaphragm comes back up.
Yes, correct.
So let's tie this into the Valsalva and why. So one of the rules kind of we have is that we don't want change. Listen, we say rules, but there's a certain amount room for error and variability and imperfection with what we do. And this is also why we never suggest training at max effort all the time. The more you train at max effort, the more you are susceptible to issues when you train, but we want to reduce change in position under moving load as much as possible. And just because you can't see something does not mean it's not changing position. And
this is great. Keep going. Keep going.
You're like, I love it.
Yeah. Nerding out. Keep going.
When we inhale, the diaphragm moves down. And when we exhale, the diaphragm moves up, right? So if you are inhaling while you are deadlifting or squatting or bench pressing, and if you are exhaling while you are squatting, deadlifting, bench press, any type of resistive exercise,
which there are exceptions, and we can mention that,
and we'll talk about that. But we'll talk about those more in like the dysfunction episodes. But if you are inhaling or exhaling while you are trying to move a heavy load, then there is a change in position under moving load of your, not just your diaphragm, because the diaphragm, like we talked about, this cylinder affects every single other muscle in your core. And we don't want that change in position under moving load, because these are stabilizer muscles. They're intended to not move when you are moving.
And then we have a change in pressure, which also equivalates to,
changing of the length and position of the back muscles, the abdominal muscles, and the pelvic floor muscles. And I'm going to say this like 1,000 times. Just because you can't see it does not mean it's not happening. Okay. And that's part of the problem with like pelvic floor and pelvic abdominal dysfunction and back dysfunction, is that you can't see it, so we have to be, then this is really why we monitor and
problem solve and
but monitor and suggest that you don't train too heavy for extended sets or extended period of times in your training, because the more fatigued you are, the higher intensity that you're training, the more susceptible you are to more movement under moving load. Does that make sense? Change in position under moving load. Okay, I'm off my high horse.
Yeah, that was so good. And then Rori, so exactly going off of that, the pelvic floor mimics, it's people call it your pelvic diaphragm, because it mimics that same movement of the diaphragm. So as you breathe in, that pelvic floor should be dropping and relaxing, or just dropping and relaxing. And then as you exhale, it is coming up and changing position upwards. Now you probably are thinking, but why do we want the pelvic floor to drop and relax when we inhale, and then we take this big breath in and then they're relaxed, and then that doesn't make sense? Yes and no. So when we're restful breathing, or we're just, restful, yes, we want that dynamic movement. We want that let go and that drop and relax. And then we want those muscles to return to their resting position. But when we do the Valsalva, it adds another layer to this, where yes, you take this big breath in, and yes, you get some descent of that pelvic floor. But then when you do the hold, it's like this concentric contraction of the pelvic floor that locks in. Again, remember, making that snowball, top, bottom, side to side, front to back, everything's coming towards the center.
Yep.
So you're not leaving those muscles like
in a
loosey-goosey down there.
Exactly. You're not leaving them in a relaxed state. So the Valsalva, it's not just like this endless inhalation in. It's hard to say, people teach it as this inhalation, but then exhalation against a closed glottis. I don't really teach it like that. It's not that. It's you take a big breath in and you hold it.
You lock around it.
Like you just don't let it out. And that stopping of the breath is what causes this pause and concentric contraction. Isometric. I don't know why I keep doing that. This isometric contraction of the diaphragm and the pelvic floor in place to lock in that, or pack in that snowball, that sandcastle. And that is what creates this increase in intra-abdominal pressure, this stiffness and rigidity when you're lifting.
Yes.
Love this podcast.
It's so good. We're
Okay.
biased, but
I just think that like people don't talk about this that much. And we can talk about the Valsalva as much as we want. We can talk, we can do episodes on the back, and people talk about that stuff all the time, but it's very rare that you hear people talking about the function of the inner core. So,
Yeah.
is that everything about the diaphragm for now? Or do you want to move on to the pelvic floor?
Yeah, I
All
think
right.
so. I think we can go to the pelvic floor.
All right.
Last but not least.
Last but not least, but really the area that people will see a lot of dysfunction in the pelvic floor for various reasons: trauma, birth,
Stress. We're stressed people.
stress,
Poor posture
surgery,
and Mhm.
just so many different injuries to the hip and the back can cause dysfunction in
Mhm.
the pelvic floor. So
gut
how
issues.
what
Every
is
oh.
oh gosh, gut issues. What is the pelvic floor? How does it
Yes.
function?
So the pelvic floor, so this group of muscles. So first off, there are 3 layers. We don't need
There's
to
always layers
yeah,
in our
just
body.
yes, layers and layers, which is I mean, it's amazing to like
It's
think of
good. It's a
our
check
yeah.
system, like,
Yeah.
and I think that's important because like we talked about how, we're designed to work optimally. Like we don't come out of the womb with issues, but we have this check system. So there's not one muscle that does
One thing
one
and that's your
thing,
job.
and there's not just one function that one muscle takes care of.
Yes.
And so we do have like checks and balances in place so that if something starts to fail, there's something to back up what's happening. So we don't necessarily see the dysfunction until it's like really a dysfunction, especially in the pelvic floor,
Yes.
because again, we can't see it and we're
Yes.
not aware of it. So you go ahead and talk about all that
Yeah.
stuff.
Well, no, I mean, it's true because like the pelvic floor, it's so connected to so many parts of our body in a sense, like the hip, and we'll get into the relationship not today, but another day with the hip relationship between the hip muscles and the like there are pelvic floor muscles that attach to the hip. So, we have relationships with the hip, the pelvis, the low back, the abdomen. So yeah, it's the pelvic floor really unknowingly compensates a lot for, other areas. And then eventually it gives and it does it because it's doing a much bigger job than it's meant to, in many different ways. But so basically this group of muscles, it's 3 layers. For our purposes, let's just think of it more as 2 layers. And we're going to think of these 2 layers as like the inside layer that are, that's inside us, more deeper inside of us. And then the outside layer that's like closer to our pants.
Hmm.
So first off, the pelvis in general that these muscles are attached to is like a bowl without a bottom. And the bottom of that bowl is covered by a sling of muscles, which we refer to as the pelvic floor muscles. This group of muscles, they go from the pubic bone in the front all the way to those sit bones, the bony parts of your butt,
Hmm.
and then go all the way back to the tailbone. And these muscles surround each one of our openings. So females, we have our urethral opening where our urine comes out of, our vaginal opening, which is reproductive, and rectal opening, which is, bowel movement, defecation. For men, we only have 2 openings, the urethral opening and the rectal opening. So these muscles not only extend like a sling from front to back, but they also go around. They have specific other muscles that surround these openings, of course, to help us hold back urine and bowels, our bowel when we want them to, and then also let them out when we want them to. That's again in an optimal function. That's what they're meant to do. Part of what they're meant to do. These muscles are like any other muscle in our body. So just like our trap muscles, our upper traps, these muscles can function appropriately. They can have tension and tightness. They can get trigger points. They could be weak, a combination of all 3, but that's how these pelvic floor muscles function as well. And what's interesting is a lot of times, we don't even know that those muscles like are there and like how, like just to visualize them, like we don't even know that that's how they're oriented.
Right.
But then to have to know, okay, what's contracting? The Kegel, we'll get into
Oh
that.
yeah, we have
But
a
what's
nice episode
contracting?
on Kegel coming up for you.
Don't miss it. We talk
It's
all
a good
things
one.
Kegel.
It's good.
But anyway, so these muscles, the deeper layer of these muscles, though, function more like our typical bulky, like muscle belly muscles. So when I say muscles that have like a muscle belly, we think of like our biceps. Yeah. Our biceps, our quads, our glutes, like these muscles have a big muscle belly in the middle and they contract and relax, and we have conscious control over them more. So when we say, oh, I want to pick up this glass, we contract, we tell ourselves, or no, I want to stop. I don't want to pick it up. I want to put it back down. So that's the deeper layer of these muscles. These muscles are most involved in, again, if you feel like you have the urge to go to the bathroom, you can contract these muscles and do like a Kegel. Like that's the function of these deeper muscles, is that knowledgeable or aware, you're aware of this contraction. The external more external layer of these muscles is more involved. So imagine a triangle and then a circle around, like in the middle of that triangle. Those triangle muscles, these are like, again, the more superficial muscles. And they are almost, if you look at them, like when I dissected cadavers in my PT school and then my residency, those muscles are like they're painted on. Like it's really interesting. They don't have a thick muscle belly. They're not our conscious control of like contracting and relaxing. They are just kind of like, weirdly to think of, is like if you have a sheet blowing in the wind, like your bed sheet, it's like that's how those muscles just kind of move and groove with us. But when we have tension, when we have fear, when we have pain, when we have any of those things, there's tension and protection that gets created in those muscles. And that's their contraction more so, is this like tensing. Yes, it's involved with some of that urination and defecation as well. But when we see these muscles functioning, when we see symptoms like pain or urgency, urinary urgency or bowel urgency, frequency, etc., prolapse, things like that, we see more so tension in these muscles because they're overworking and they're doing, excuse me, they're overworking and doing a much bigger job than they're meant to. So going back to the normal function.
Well, so I just want to point out, and we talk a little bit about this in the Kegel episode. When something has tension and it's chronically overworking, not chronically activated,
because they're always
active. When it's chronically overworking, it creates a significant amount of fatigue in the muscles, and fatigue is when the muscles start to fail. It's not because they're too weak, it's because they are tired. And that's why they're failing. It's just like when you're driving and you're tired and you fall asleep, you might veer off the road. It's not that you're a bad driver, it's that you were tired.
Yeah.
And that's why you veered off the road. It's not like you don't know how to keep your car straight, So that I just wanted to point that out because it's not it's like so many times I've heard people say, well, it's a weak pelvic floor. And it's not that it's weak, it's that it's overworked.
Yes.
Burnt out.
Yeah. Like again, you'll hear this example in the Kegel episode, but it's like if you were doing a wall sit all day and then you're like, let's go train and let's squat heavy. And then your muscles are like, ow, and I can't, and I'm tired.
I'm
like,
done.
ow,
I'm checked out.
No, thank you. I can't I can't possibly do more. And
right, exactly.
So in general, these pelvic floor muscles again are involved with not only our organ functions of urination, defecation, involved with reproduction and sexual function. They also are involved with pelvic stability, hip stability, and again, as the overarching foundation is core stability, inner core stability. So yes,
yeah, we talked about how with the Valsalva that when we talked about the diaphragm, we talked about how those two work together to create this compact system with our outer core, like the ring of our abdomen and spine. But talk to me just a little bit about how the pelvic floor functions to contain our inside. Not well, yeah, I guess. Well, we talked about inside, but how does urination work?
Yeah.
How does pooping work?
Yeah.
Because I think
Pooping
it's
101.
I think it's important to know how proper pissing and pooping happens.
Yeah.
Proper pissing and pooping. How I think it was that called alliteration.
Yeah.
I think so. How those work, because people piss and poop when they lift, and that's dysfunction. So
Yes.
so if you are peeing and pooping
Or
periodically,
gas.
my
Even
gosh,
gas too.
pissing or pooping periodically,
The triple P.
triple P. Is there a P word for farting?
Yeah.
Popping? I don't know.
I don't know.
If you're pooping, peeing, or farting when you're lifting, that's not functional.
Yes.
So let's just talk about the normal function, because we will talk about all those things in later episodes this month. So just give us like the quick down and dirty, literally.
So
I know,
the
as a pelvic health physical therapist, I know that there's like all these different stupid things that you can just laugh at, like even your initials.
Oh yeah.
BM.
Bowel movement. Like
I
I
know.
go from BJ to BM.
I
Like it
know.
just doesn't.
She used to be BJ and now you're BM. I just laughed when you got married. I was like, you could have traded for a better initial, you know?
Yeah. No, especially it's just more fitting now.
I know. It is more fitting. Okay, so how
But yes.
do our poops and pees work?
Okay. So just like our pelvic floor muscles, they are muscles. So our bladder is also a muscle. Our rectum and our bowels are also muscles too. They are just slightly different muscles because, again, obviously we're not consciously controlling them. They're smooth muscles. Again, more like those external pelvic floor muscles, kind of more painted on, and we don't have as much conscious control. It's more of a neurological function. So, when we are in the most basic sense, our bladder muscle and our rectum, or sorry, I guess our rectal muscles, they work opposite to the pelvic floor. When our bladder and bowels are filling up, obviously, like those muscles need to relax to allow those spaces to fill up with, again, urine or feces. So those muscles are relaxing, but the pelvic floor is at a low level contraction to hold the, to keep the cap on, essentially, to keep let things
I
let
love
things
that.
fill up and not just come out. Then whenever we are consciously saying, okay, I'm on the toilet, time to go to the bathroom, we have that neurological message that says, okay, bladder or bowels, you contract, and pelvic floor, you relax to open up the cap, essentially, and then we empty. Now, again, there are many reasons that there could be dysfunction in this system. Whenever we are thinking of lifting specifically, it's almost like kind of two categories. Yes, there can be a problem in the system, and there's actually a dysfunction with those muscles and that coordination. And it's something else outside of just pressure management and fatigue and form. So that's a different story for another day. But when we look at training mostly, and people are lifting and again pissing themselves, or they can't hold their gas back or whatever. Usually what's happening in this case is, one, we are taught to Valsalva incorrectly. And so we're either pushing down and bearing down instead of compacting and creating this compacting motion with the muscles. So we're actually kind of either letting go of those pelvic floor muscles, or we are pushing so much pressure that the pressure is more than what the pelvic floor can hold back. Or again, those muscles are just so fatigued, or we haven't, the programming isn't as optimal, or the form is not as optimal for those muscles to do their job the way they're meant to. So again, that pressure, intra-abdominal pressure, is overriding or greater than what the pelvic floor can hold back.
Yeah. And we have a whole episode on this, and Bree wasn't on for that episode. I did it with Alyssa. But the episode that I did with Alyssa was essentially what we presented on at CSM related to powerlifting urinary incontinence. So if you have questions about powerlifting urinary incontinence specifically, we have an episode on that. And we are going to dive into all of these things. So we have that episode on powerlifting urinary incontinence, and we have 2 or 3 articles on, and I'll link all those in the show notes. But we haven't finished the series on PUI on the website. It's just been like I said, like I started those articles when we were at CSM presenting together in 2020 when, shit hit the fan with the world and I got pregnant. So it's been a challenge for me to kind of find the time to finish those articles, but we do intend to finish those articles to kind of align with everything that we're doing here on the podcast
be
as
continued.
well. Yeah. So I'll link all those that episode and those articles in the show notes. But in terms of the fail, and we have to kind of be very specific here because one, our podcast is not medical advice, but 2,
Yes.
you're peeing and pooping and farting when you're lifting can be only related to powerlifting. It can be related to the mechanical issues, anxiety, or or anxiety related to training, or training and competing, or your program and technique,
And
equipment, technique, all that kind of stuff. So, powerlifting urinary incontinence is specific to the person who has not had pregnancy or deliveries, has not had trauma or injury or disease to the pelvic floor, and has not started menopause, has no other risk factors for urinary incontinence, and is between the ages of 18 and 35.
And does not have symptoms outside of training.
And does not have, very specifically, does not have symptoms outside of training. So, but if you do have symptoms outside of training, there are definitely ways to manage your symptoms inside of training.
And that gives you, like, in my mind, as like a specialist, like when I hear symptoms outside of training, that tells me that maybe there's more involvement in and of the system, and we need to work on addressing possible in coordination and retraining of that system before then we progress back into, or not even before we progress back into, but before we then continue progressing the system. We almost need to get things back on track and then progress from there.
Yeah, I think that's a really important point. Is that if your symptoms are only within training, you probably don't have a pelvic floor issue.
Yes,
like there's probably not an issue with your pelvic floor. It's probably related to training, your equipment, or your technique, your programming equipment or technique. So, but when we start to have symptoms outside of training, then we have to say, okay, we really do need to look at the pelvic floor. Or if we can't resolve your symptoms in training with managing all of those other things, then we want to look at the pelvic floor. But I do want to wrap up this episode because we have so many good episodes coming to answer all of your questions related to pelvic health. So diastasis recti, hernias, incontinence, hip pain and back pain related to the pelvic floor, pregnancy and postpartum training, all of those things. We have a lot of episodes. Oh, Kegels. Oh gosh, Kegels. That episode's already recorded and it's fire. I can't wait for you guys to listen to that episode on Kegels. If you're a man, if you're a woman, if you're anything, if you identify as anything, whatever, I don't care if you're whatever, like go listen to
check
that
it out.
Coach, clinician, whatever, physical therapist, athlete. The Kegel episode is for every single person because everybody's heard of a Kegel and everybody has the wrong idea about Kegels. So, with that said, Bree, what a fantastic first episode for you on this podcast. I'm so excited for all that's to come. If you'd like to learn more about Bree, I will connect. What is your Instagram? Tell people what your Instagram is.
Oh gosh.
Oh yeah, you're I know. She's on Instagram a lot. She has her PRS account, so she's getting your PRS account.
This is so bad. Pregnancy brain.
Oh yeah, Breanne is pregnant. She's due in August, so we're doing all these episodes before.
So but if on these episodes this is June.
She's due in August, so these will be way before.
It'll be good. But if I just don't remember things, it's that's
why.
why. But my Instagram handle is Breanne Julia, BREANNE JULIA_PRS. And if
Yep.
you're on if you follow Rori or you follow Progressive Rehab and Strength on Instagram, or Alyssa or John,
Yeah.
you'll find me connected to
you'll
them
get
as well. So
exactly. You can check her out on her website, progressiverehabandstrength.com. She has a little bio on there, and her, well, I'm not going to put your email in. You can connect with her on Instagram. If you reach out through the free consultation form on our website, which I'll also link in the show notes, and you've got a pelvic health issue related to, it can be inside and outside of training, and you're concerned about it, Bree is your go-to girl. If your physical therapist in person, or your urologist, or your urogynecologist, or your OB, or your gyno are not answering your questions or finding you a solution, Bree is the closer. Bree will answer that for you, and she'll help you figure it all out. So you can submit a free consultation form through our website, and I'll hook you up with Bree. And that's it for now. I'm like super excited for everything that comes. And I should have said this at the beginning, but if you're listening to this episode and you need visuals for anything that we've talked about, we do have this episode up on YouTube with images overlaying the things that we are talking about. All right, Bree, we'll see you guys next time.
See you guys soon.